the two big misconceptions. One is pelvic pain can only happen in women.
Yeah.
That is 100% not true.
The podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a physician who is subspecializing in pain medicine. In this episode, I got something special for you. We discussed pelvic pain with Dr. Yogita Tailor. Dr. Tailor was extremely generous with her time in doing this podcast, so I'm very grateful for it. She is definitely the sort of person you want to help manage a challenging condition as pelvic pain can be. She went to undergraduate at the University of Maryland and then medical school at the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. She completed residency in physical medicine and rehabilitation at Sinai Hospital of Baltimore. She's an expert in both men and women's sexual health and skilled in treating pelvic pain. Pelvic pain can be disabling and severely impact someone's quality of life. It can affect both men and women, and often, given the inherently sensitive nature of pelvic pain's location, it is not only difficult to discuss in public, but also in private with a healthcare practitioner. I know the awesome work that Dr. Tailor is doing is helping to break this stigma. As always, thank you so much for watching and or listening. I hope you enjoy this episode and learn something.
When it comes to pelvic pain, there's often a stigma behind it.
Yeah,
People
right.
don't want to talk about it. People may not understand it, or they might think, hey, this is normal and this is just something I got to deal with, and they kind of like push it aside.
Mm-hmm.
And in my opinion, also, I feel like in our medical training, we don't get as much training time.
Absolutely.
The underlying factors related to pelvic pain, the secondary aspects to pelvic pain. And so over the last decade, this has grown into a really big interest of mine. And it's amazing what we've been able to do here.
Yeah, absolutely. I agree with you completely. The pelvis is kind of treated like a black box when even the anatomy. I feel like you learn the anatomy, as you do with all parts of the body. The spine and the pelvis, I feel like, are the two places that people are just like, yeah, there's stuff there. And I mean, we do study it, of course, but it is less of a specific thing we nail down in medical school and residency. And as such, because it's such a vague term, how in your mind do you break it down when you see patients?
Yes. So in a very general sense, I feel like pelvic pain can be from anywhere from like the belly button to the thigh, right? So that will encompass like lower abdominal pain, lower back pain, SI joint pain, groin pain, and then you can even think about like tailbone pain. And then what sometimes leads patients in a different direction than maybe a pain or physiatrist is when people will have like intercourse pain or testicular pain or vaginal pain that they feel it may be more GYN or neurologically related. Because sometimes things get aggravated even with like having to go to the bathroom or all of that. So there's definitely a big neuromuscular component when talking about any of the things that I kind of just mentioned.
Sure. When patients come to you, are there specific, pelvic pain is so diverse, as you just said, coming from the lower abdomen even, that's more severe than I'd even think of it when we're talking about pelvic pain. But are there specific things patients usually describe their pain as when they're talking about pelvic pain?
It can vary.
Yeah.
So again, when patients come in with pelvic pain, I want to kind of hear what they mean by the pelvis, right? So for some people, it's like a deep, like lower abdominal pain. For some people, it's all the time. For some people, it comes and goes. And it can be situational. And so it can vary. And that's kind of what makes it complex. I often tell patients, like, the pelvis is a big intersection.
It is.
And sometimes the initial things that people may think of are organ systems, right? Bowel, bladder, genitourinary system. hips, even low back. But then there's our pelvic floor, which is holding everything. And it's a big central part of our core. I would say like it's the floor of the core. So your abdominal and back muscles, the pelvic floor is connected to that. And so when it comes to the different symptoms, it can vary from I'm having like constant daily, vulvodynian type symptoms, or constant lower abdominal pain, or it can be an intermittent thing. Like my pain only happens when I sit. My pain only happens when I go to the bathroom, or only with intercourse. So it can vary.
Okay. Person to person. What are some of the more common diagnoses you see, like coccydynia, or what would you say like the top three most common that you see?
Yes. So my top three, so endometriosis is our female population big diagnosis that we see. So oftentimes a very common thing is I hear, hey, pain initially occurred when I got my period, and it was a very cyclical type of pain. And sometimes depending on the chronicity, that time frame can also change, where it was only on my period, then it becomes a few days before and a few days after, and then weeks before, and now it's like a constant thing. Tailbone pain is also a very common symptom that we see. And even like growing pain is a very common symptom that we see. And so it kind of travels down into the leg. Sometimes they've already had hip evaluation, but that kind of sometimes gets ruled out. But oftentimes it's a combination of a few things. So it's rarely like I'm here because this, but when I kind of poke and prod through, there's like also like urinary symptoms, urgency, frequency, bowel movement pain, rectal pain. And sometimes it's a constellation of symptoms that I see.
Sure. And with endometriosis, would you mind describing sort of the pathophysiology of that a little bit?
Yes. So endometriosis is when you have endometrial-like lesions, but it's outside of the uterus. And it could technically be anywhere outside of the uterus, usually in the pelvic area. Could be on the bowel, could be on the bladder, could be in the pelvic cavity, in the cul-de-sac. Technically could even be higher up in the diaphragm, anywhere else in the body. But it's a very inflammatory disease process. And, even in 2024, I feel like we don't have all of the answers. The questions are, some people, are people born with endometriosis-like lesions, and it gets kind of triggered during menses? It's all a big question, but those endometrial-like lesions can cause irritation, inflammation, leading to pain. And again, the most classic symptom is painful periods. And again, it's painful periods which cause dysfunction. Women are missing school days and work days. And, I've had patients say their periods are affecting what they do on a daily basis. But that inflammatory process can also lead to other dysfunction, including painful bowel movements, urinary issues, and inflammation of that pelvic floor. And so that pelvic floor diagnosis also sometimes becomes a secondary issue due to endometriosis.
Okay. So you were mentioning the pelvic floor, and I just wanted to see if we could touch a little bit on the anatomy that you typically, talk to patients about and that you typically have in mind.
Absolutely. So like I said before, the pelvic floor is part of our core. So it's a constellation of muscles which are holding everything. So I just took out the organs. So we have, for females, there's the uterus. There's also the bladder inside for both men and women. And then we have our bowel. So those are the big organ systems. Again, prostate would also be in there. But the pelvic floor is essentially holding all of this. So it's a layer of muscles. It's kind of like a hammock of muscles. It's attached to the tailbone in the back. And that's why tailbone pain can be often a symptom of pelvic dysfunction. The pubic symphysis in the front, and then the iliac crests on the side. And these muscles together collectively are the levator-ani muscles, but then you can kind of separate them out. There's the iliococcygeus, pubococcygeus, puborectalis, which may be familiar to you from anatomy, but again, sometimes
I mean,
through it.
I reviewed it prior to this podcast, but prior to that, I would have completely forgotten.
Yes.
So, yeah.
And again, so externally, there's muscles out here. Again, this is a female pelvic floor, but males would be the same.
Yeah.
So there's superficial muscles, including the sphincter. And then the other aspect in terms of the neuromuscular aspect of the pelvic floor are the nerves that are coming out of it. So again, my eval always includes a lower back exam because the nerves that come out of the lower part of the back will enter into the pelvic cavity, and then the nerves can kind of separate out within the pelvic floor as well. So that's a big aspect of a lot of the things that I treat, the nerves and the muscles of the pelvic floor.
Excellent. And the nerves being specifically, is that pudendal nerve that you're often treating?
Yes.
Okay.
And the pudendal nerve is one of the biggest nerves in the pelvic area. And again, it travels out of kind of that Alcock's canal. It's kind of right where our sits bones are.
Okay.
And then it has so many different branches. It can travel into the back area, the rectal area, perineal area, all the way into like the testicular, even the tip of the penis for men, clitoral area for women, so into that vulvovaginal area as well. So, and oftentimes even that pudendal nerve can send pain into that lower abdominal area as well. But next to the pudendal nerve, there's the posterior femoral cutaneous nerve that has branches around it. And then there's, coming from a little bit higher up, there's the ilioinguinal nerve, genitofemoral nerve. But I would say the pudendal is the bigger nerve.
Okay. When you have a patient comes in, how do you differentiate between pelvic pain and abdominal pain?
Yes. So differentiating from that. So a big part of it is hearing their journey. So we spend a lot of time talking about symptoms, how long they've been dealing with this, and if they've had any other workup done. Oftentimes, before a patient comes to me, they may have already seen either their primary care or GYN or urologist. Sometimes not, but again, if there's been any workup done, and we try to see if there's any association with what they're doing versus what they're eating, time of the month, activity, all of that. And then the other big aspect to help differentiate is that exam. So my exam will have a full neuromuscular exam. So back, hips, abdomen. So again, trying to figure out if there's a trigger from the back, if their range of motion of their hips or Faber-Federer exam is positive. Abdominal exam, again, is it coming from something deeper within versus the neuromuscular system versus if there's a hernia. So I kind of check for all of that. And then the other aspect is the lower pelvic exam. So we do an external exam. So feeling kind of the neuromuscular aspect externally, and then also an internal exam. So that's a big difference in terms of what a lot of other physiatrists or pain doctors would do would be that internal exam. And I'm not looking for, organs like prostate or ovaries or anything like that. I'm trying to feel what those muscles are doing. Are they overactive? So that's something we see very often with pelvic pain, is that these levator ani muscles, these pelvic floor muscles are hypertonic, they're overactive. And then when you push on the different areas corresponding to the different nerves, we can test if there's any pain, allodynia at those nerve sites.
And that kind of leads us into, I was going to ask this question later, but I think it's a perfect segue for pelvic floor therapy.
Yes.
What is that?
Absolutely.
People want to know.
Absolutely. So pelvic floor therapy is a huge part of our treatment plan. So working with a good pelvic floor physical therapist. So again, similar to most physiatrists, we work well with therapists to help augment patients getting better. And a pelvic floor physical therapist, again, and you want one that has good training, would be able to look at the neuromuscular system of the back, but again, also the whole body. And a big part is that they would be able to do some internal work and understand the anatomy as well.
Right.
When it comes to pelvic floor dysfunction, again, when it comes to pain, a lot of the things are overactive.
Okay.
But then you could also have an underactive pelvic floor, and that leads to other symptoms such as incontinence and things like that, which a pelvic floor physical therapist would also be able to treat. But when it comes to pelvic pain, their role is to help also teach these nerves and muscles to calm down. And sometimes there's a biomechanical aspect. Sometimes There's manual work that needs to be done. It's a reteaching of how we're holding our body as well. So a very important aspect to treating pelvic floor is good pelvic floor physical therapist.
Do you give patients exercises, and do you write specific stretches or exercises when you prescribe pelvic floor therapy?
Yeah, absolutely. Like when it comes to different symptoms of pelvic floor, again, a big part of it is down training when it comes to pelvic pain. Many of my patients have a very tight pelvic floor and things are overactive. So the big things we recommend include opening exercises, yoga-based exercises. So stretching like, cobra stretches, butterfly stretches. But in terms of the more specifics, I often have the pelvic floor physical therapist work one-on-one with the patient.
Got it. Okay. When should a patient come see you for pelvic pain?
Yes. So when pelvic pain, number one, has been going on for enough time. And
how long would you say is enough time? Like, is it 2 weeks? Is it 2 days, or is it like 2 months, 2 years?
Yeah. I mean, it could be a month beyond, right? And when it comes to the triggers of the pelvic pain, it could be something like a urinary tract infection or a cyst or something like that, which you may want to see your primary care or GYN or urologist first. But if this is persistent, this is not calming down, there's a huge role in getting that neuromuscular evaluation done.
Okay.
So oftentimes my patients will have pain. I would like to see them sooner rather than later because when pain becomes more chronic, it's harder to retreat. And it's not harder, but it takes longer.
Right.
But anywhere from a month and beyond, we've had patients with months of pain, but also decades of pain as well.
That's why I more so imagined when I was thinking about pelvic pain is that patients that have been struggling for quite some time, but that's why it's good to get the word out about this.
Yes.
What do you wish your colleagues knew about pelvic pain and when you refer?
Absolutely. So the big thing is oftentimes pelvic pain does not show up in imaging, right? Like I think in classic American medicine, we're taught, hey, if something's going on, let's check some lab work, let's get some imaging, let's see what's going on. But oftentimes imaging is very normal with my pelvic pain patients. And then they kind of the patients kind of feel maybe like, hey, maybe I'm imagining this or this is not real, but their pain is definitely real. And if it's coming more from the neuromuscular aspect, it often does not show up on imaging, but their pain is very real. And we don't want to dismiss patients if nothing comes back on traditional imaging.
Are there specific patient populations? Of course, it seems like we often think of like a female patient population, but are there some patients within females or males or between that experience more pelvic pain than others, or that are things that make them more prone to pelvic pain?
Yes. So again, like I mentioned, endometriosis can be, and again, we can't really pick out who has endo and who doesn't, but that's a big patient population. But then I also see a lot of athletes. Again, especially if you're doing more heavier lifting, more repetitive, like there's a lot of engagement of the core, and that includes that pelvic floor. So whether there's underlying hip issues like a labral tear or tailbone issues or anything like that, that has a predisposition to developing pelvic pain. Also, again, classically, we'll think about our postpartum females. Again, between delivery, whether it's vaginal delivery or C-section, like that pelvic floor takes a lot of brunt out of things. And then we've also have our menopausal, perimenopausal women as well who are going through changes in their body, sometimes, hormonal changes that affect the whole body, right? Like we often think like hot flashes, but when it comes to menopause, there's a lot more other symptoms, including genitourinary syndrome of menopause, dryness, pain with intercourse, but also, neuromuscular changes as well. So back pain and things like that.
Are there any misconceptions about pelvic pain that you like to like kind of dismiss when you first see a patient, or just out there in social media you see a lot?
Yes. So two big misconceptions. One is pelvic pain can only happen in women.
Yeah.
That is 100% not true. Men and women have pelvic floors. The anatomy is pretty similar, with the exception of minor changes in angles and things like that in size. But men and women have pelvic floors, including the muscles and the nerves. And number two, even in women, people may think that, hey, this is mainly just for pregnant or postpartum women. We see plenty of women out there that it's not necessarily correlated with having a baby. It could even be women that have never had children. So that's another misconception as well. So that is definitely something that we see. And also, there are symptoms that are considered to be normalized. Period pain, postpartum pain, incontinence, and it's technically not normal. It can be common, but it's not normal.
Got it. Okay. What, outside of the pelvic floor therapy that we've discussed, what medications or procedural treatments do you offer patients?
Yes. So procedural treatments, so depending on exam and chronicity, patients often benefit from a combination of nerve blocks, trigger point injections, again, depending on their exam and location, as well as neuromodulators, nerve medicines, suppositories are something that we can prescribe very commonly to target into that pelvic area. So suppositories, not necessarily for bowel movements, but to help calm down muscle tension and nerve tension, so nerve inflammation. Working with a good nutritionist can be helpful with an anti-inflammatory diet, cognitive behavioral therapy as well. So those are the big aspects that we incorporate. And oftentimes it's about doing it together. And I think in classic medicine, we say, hey, try this first, and then this, and then this. And if it doesn't work, we'll try the next thing. But especially if pain in general has been going on for a really long time, doing it all together can make the biggest impact. And we see that a lot with chronic pelvic pain.
Are there any patients you refer to surgeons?
Yes. And again, as a physiatrist, my ultimate goal is to help patients avoid surgery. But when it comes to disease processes like endometriosis, oftentimes they may need a surgeon in order to take out those lesions. And you want them to be a specialized surgeon, because there's different techniques out there between burning endometriosis and excising endometriosis, and the excision is a more targeted therapy. Also, for these patients, you want to preserve organs.
Do you have, we're talking about hysterectomies here, or what else are we talking about? Oophorectomies too?
That's a big one. So again, some patients have been told, hey, a hysterectomy is your only option, and the uterus is taken out. But like I said before, endometriosis is outside of the uterus. And so taking out the uterus often is, it's not a cure for endometriosis. And those lesions are still in there. They're still inflammatory. So we want to make sure that we are minimizing these unnecessary surgeries and maximizing function.
Absolutely. How do you see pelvic pain impacting people's quality of lives? And also, I guess more specifically, how it impacts just sexual activity?
Yeah, so huge impact on quality of life. And sometimes it's things that we take for granted. So sometimes I have patients that come in and pain is just with sitting, right? And think about, like, we sit every day and we don't think about it, but these patients, they can't sit. They can't sit for more than a certain amount of time, or they can't sit at all, and it just spirals their pain. So sitting, bowel movements, it hurts to have a bowel movement, or they feel like they have to urinate every 20 minutes or so. And so they're in the bathroom all the time. That impacts work. It impacts, day-to-day activity. It impacts, relationships and things like that. And then intercourse, right? Some people say, hey, like, intercourse is painful. And so they either normalize it or then they avoid it. And that can also contribute to infertility, right? We think about infertility as kind of that deeper aspect, but you can't have intercourse, and it's also can contribute to infertility. And even in men and women, sometimes it's pain after intercourse. So the aspect of climax and those pelvic floor muscles overfiring in patients that already have tight muscles can flare their pain as well. So that is something we see often as well.
Are there specific patient testimonials you can think of or share with us that patients have been dealing with that for like decades? And then, it's simple as like pelvic floor therapy helps, or maybe the trigger points, nerve blocks. Is there anything that comes to mind readily about that?
One patient right now is, you just talk about intercourse. So she's had painful intercourse from the beginning. So let's say 10 years. And she saw her OBGYN. The OBGYN tried a few things and then ultimately referred her to pelvic floor physical therapy. And she had pelvic floor physical therapy, but there was also an anxiety related to that. There was different factors where she wasn't progressing in pelvic floor physical therapy. And she had several sessions. And then the pelvic floor physical therapist also referred her to us. So when we also incorporated adding suppositories, adding the injections, we saw progressive change in her symptoms where we didn't touch upon this, but there are tools out there to help with home exercises, including dilators. And she was able to progress dilator size week to week with our injection series in combination with physical therapy. And she was able to have pleasurable intercourse afterwards, and her friends celebrated.
That's awesome. Nice. Good. Yes. Excellent. So for people that might be listening now, what advice would you give them that are experiencing pelvic pain?
Yes. So number one, don't deny your symptoms, right? Again, sometimes traditional medicine may not pick up what's going on. And again, and that includes even things like endometriosis. I said how sometimes imaging doesn't pick up things. Endometriosis is included with that. So even if you've seen your physician, you've had some workup done, nothing really comes out of it, don't feel like this is coming out of nowhere. So that's number one. Advocate for yourself and don't feel like your symptoms are not matching up to what's going on. Number two, kind of do your due diligence, right? And when it comes to the pelvic floor, there's still more awareness that needs to be made. I'm seeing a lot more of it in the last 3-4 years with social media and podcasts like this. But do your due diligence and say, hey, like, is this the right fit for me? And am I seeing someone that actually understands? And also the stigma of even talking about this with friends and colleagues and things like that, because people don't want to talk about it, and they kind of go through their days with kind of just dismissing it, ignoring it. But when people start to talk about it, people may say, hey, I'm also dealing with this, or I know someone dealing with this. And so forming that network is going to be important. Just like, other diagnoses where there's, support groups and things out there. There are support groups out there for pelvic pain patients, endometriosis patients. So the resources are out there. Sometimes we just may need to look a little bit harder.
Excellent. Dr. Tailor, thank you so much for your time and being on the show.
This was a pleasure. This was fun.
Good. I'm glad you enjoyed it.
All
Thank
right.
you so
Thanks,
much.
Derek.